30ನೇ ವರ್ಷದ ನಮ್ಮ ಒಂದು ಸೆಲೆಬ್ರೇಷನ್ ಅಂಗವಾಗಿ ಇವತ್ತು ನಮ್ಮ ನೆಚ್ಚಿನ ಗುರುಗಳಾದಂಥ ಮುರಳೀಧರ್ ಶರ್ಮಾ ಅವರ 5ನೇ ಸೀರೀಸನ್ನು ನಾವು STM 89 ಬ್ಯಾಚಿನವರು ಹೋಸ್ಟ್ ಮಾಡ್ತಾ ಇದ್ದೇವೆ. ಮತ್ತೊಮ್ಮೆ ಬಂದಂಥ ಎಲ್ಲ ವೈದ್ಯ ಮಿತ್ರರಿಗೆ ಹೃತ್ಪೂರ್ವಕವಾದಂಥ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೇವೆ. ವಂದನೆಗಳು.
Today we are into Dr. Muralidhar Sharma lecture series number 5. As you all know, we started this series like in first lecture, Dr. Sharma explained about basic principles of Ayurvedic practice. Similarly, in second session, we discussed about respiratory tract diseases or Pranavahasrotas diseases. In third series, which was conducted at Sharda Ayurveda Hospital in Mangalore itself, that was about GI tract disorders. And fourth one, in previous session, we discussed about diabetes mellitus. Today, we are discussing about Rasavahasrotas diseases or management of hypertension and cardiovascular diseases.
Friends, greetings of Dhanvantari Jayanti and Deepavali. After having a controversial disease of diabetes mellitus, now we are going into another controversial disease, that's hypertension, which I consider as a Rasavahasrota Dushti. Again, we will not go into that controversy like whether it's true or not. Next slide. That concept of that disease itself is a unique feature. Like initially, in the earlier days of physiology, people knew that there was something like a circulating pressure, but it could not be measured, and its importance in the disease was not known till 1896, where the pressure could be measured by a cuff, that sphygmomanometer, it was invented. Till then, the study of blood pressure was only in the experimental animals in the labs, where animal would be sacrificed. You will have to put a tube into the carotid artery and then measure the pressure and so on. So it was never considered as something of a clinical importance. So clinical significance of a blood pressure as a measuring the pressure of the circulation, it came into reality only after 1896. But still, it's not yet still an established one. Actually, the idea of considering this as a disease, it was only after, next slide please, next slide, only after President Roosevelt had an accidental death. It was known that he had hypertension, and very interestingly, he was given a healthy certificate earlier, and after having the certificate in his hand, he had a cerebrovascular accident all of a sudden in a meeting, and then he died. And that became a big issue. An American president dying with a health certificate, and this was in 1906. And from then onwards, the interest about this circulatory pressure and then its value or its importance in the disease was to be considered. Earlier, it was not considered as a disease. It was considered as a physiological parameter, and it was considered as something variable. And the study about the blood pressure, it started only after having this kind of an accident where President Roosevelt died. And then the effort for further study, it started only in 1948 with the Framingham Committee. Even now that Framingham Committee and Framingham framework of assessing the blood pressure is the most important nodal center throughout the globe, which collects the statistics. After all, hypertension is a disease of statistics. That's what I say. Statistics is an interesting subject. At the same time, it's a very dangerous subject also. So, and boring. That's the other part also. But the problem would be, because it's a disease of the statistics, you will have always some confusion. Confusion in the sense statistics always is misleading. Usual quoted example, which I always quote about the statistics is, suppose a surgical procedure has 1% success rate, and a patient going to a surgeon assures the patient that you have a high chance of survival because 99 of my patients earlier have died and you are the 100th patient. Statistically, he has to survive, But what about the common sense? So common sense and statistics, you will always have an issue. And with the hypertension also, this issue is a very important core issue which we need to consider before we go into the Ayurvedic idea and Ayurvedic practice point of view. Of course, the whole issue is, next slide, about the simple, what's the normal blood pressure? About this issue itself, there is a lot of controversy. Guidelines and the normal values were standardized and then announced throughout globally, and this is the timeline. Now, I think I'm not going to the detail of all that. Almost every 2 or 3 years, the normal blood pressure was revised. Normal blood pressure, which we studied when I was a student in PG, is totally different, and all such people whom we consider as normal pressure, now they are in the severe category 2 hypertensive condition who need a more energetic treatment. Last of that, now I will not go into the details like what are the changes done in the individual setups like. The latest of that was 2017 AHA guideline. 2017 AHA guideline, next, has categorized the blood pressure under this category. And very interestingly, according to that category, 120/80 is considered as a normal blood pressure. Interestingly, I think every clinician might have experienced it. Very rarely you get a patient above the age of 40 having that 120/80. Most of the times you will have persons, I will not use the word patient, people having a blood pressure above that. And particularly in Indian conditions, the number of people having the blood pressure above 120/80 are very common. And if we consider this as a criteria, almost 90% of the people above the age of 40 would be categorized as patients and they would be requiring some treatment. That's one of the important issue. And then of course, the other categories as such would be, the elevated is considered as again up to 130 systolic. Of course, again there is another of the controversies. When we were studying, we were given have studied like the diastolic pressure is more important than the systolic pressure because it produces a cardiac load. But now there is a gradual shift to the attention. Even a single systolic pressure study also is to be considered as a hypertensive. So you will have again lots of confusion issues. But the other categories, of course, when it goes to the higher level, like when it goes to 140 by above 90, then it has to be categorized as a hypertension. That's almost a universal agreed issue. Next, but when AHA, that American Heart Association, declared that 120/80 is the standard normal pressure, all the people over the globe didn't agree. It's not only me who comments on that. There are many people who commented on that. European associations and European doctors, they didn't agree. So there had to be a compromise formula. And what you see is on this slide, they made some compromise like making up to a pressure of 120/80 as something 120/90 as considered as to be normal, and the categorization was slightly different in the European and the American association. Next, still that story is not yet over. The problem would be to record the blood pressure when to be considered as normal. The blood pressure is such a variable factor which can vary significantly throughout the day, and roughly the blood pressure would have a significant fluctuation almost every minute, or maybe at very short duration you will have a fluctuation. So which of the blood pressure to be recorded are considered as pressure of recording? So ambulatory pressure measurement, there was another of the controversy. This came into the picture. Like if you record the blood pressure throughout the day, you will have lots of fluctuation. So hence they came to a standard. The standard is you need to have a minimum 3 recordings in the resting conditions, and the 3 recordings should be done in different setup. Because there is one more. Next, there is one more called as a white coat hypertension. White coat hypertension is because white appearance of the doctors is supposed to be white coat. This is an established term. Yes, white coat hypertension is an established term. Either it could be because of the doctor or because of the environment and so on. Multiple variable factors can produce a significant change in the blood pressure. And hence, there was another compromise. The another compromise is you need to have minimum 3 recordings, and then the average of the 3 recordings has to be considered as the normal pressure of that person, and then you will have to assess like whether the patient requires a treatment or not. Still, there was lots of controversy. And latest of the compromise formula, now what I have shown in that slide, probably I think the fonts are small, but that's the compromise formula. Compromise formula is if the patient doesn't have any symptom, then even up to a level of 140/90 can be considered as normal. If the patient has a symptom or a allied complication, then it has to be considered as a abnormal. The assessment of different guidelines, so on, I will not go into that part. But the latest of that trend is the most popular standard considered in the eastern part of the country, Southeast Asia, is that ADA. ADA consideration is 140/80. Then different associations, they now consider, so wherever you go into the globe, you may have different levels of the blood pressure as normal blood pressure, and so you will have the controversies. Indian doctors, they always follow that American standards, and that 120/80 is considered as the normal, and most of the patients whom you see here would be treated keeping that 120/80 as the target value, and then the patients are treated. Next. The result is, out of what happens, like, now what you see in the graph is the total market value of the antihypertensive drugs. Every time a guideline is revised, our graph goes up, and the prediction is by 2021 it will be $3.5 lakh billion throughout the globe would be the total cost of antihypertensive drugs. So now I'll not go to a direct statement like it's regulated by the market, but the impact of the market is very visibly seen. Whether it's a coincidence or the other way, every new guideline by AHA relates to a recession in the USA. Once there is a recession in the USA, a new guideline comes in, and then, okay, I will not go beyond that, because that becomes somewhat more critical. And moreover, another important issue is, as per the WHO statistics now available, that second half of that, the left half of the slide which you see is about, previous one. Is the area where the focus has to be. Green color suggesting the Asian area, India and Pakistan, so on, the Southeast Asia portion, is the area where the thrust is now, globally the thrust is to market the antihypertensive drugs, and that's considered, they are considering that there will be a 12.5 compound annual increase in the market for consumption, and that compound CAGR of 12.5 is considered to be very high in the industrial standards, and that's what happens. I am not making any direct statements about that. The interpretation is left to you. I am not, and reading between the lines is left to you. That's the point. Next slide. Now, that's about one aspect of that controversy. Now, the other aspect, WHO again has given you the statistics of incidence of the hypertension. As per now, this standard is as per 2016 standard. Now, 2017 standard, column would be almost of the same pattern, but height of the column may be slightly raised. The maximum incidence of the hypertension is that AFR is Africa, and then comes the South Asia. These are the two segments where hypertension is considered to be quite common statistically. Next part. Now, the other part, like why the hypertension needs to be treated. You know, there are many people with high pressure and still they live normally, and it's considered as a silent killer. Most of the times a patient of hypertension would not have any symptom at all. So why the hypertension needs to be treated? There again the statistics comes in. It's all about the statistics. The statistics says that life expectancy after the hypertension gets reduced. I think you can read that. The first line is about a patient with relatively a moderate hypertension, where the life expectancy gets reduced. That last portion, now important is in that horizontal column, that colored area, black colored area, suggests about the possibility of a complication like either a coronary accident or cerebrovascular accident. So your life expectancy may be slightly normal, slightly lesser, whereas the third line suggests about the normal average life expectancy. As Dr. Shripati has said, century. Now, that's considered as normal, but if you are having a hypertension, it's expected that it could be lesser. Now, higher the hypertension, if the patient has a very significantly high hypertension, life expectancy would be shortened by almost around 30%. Almost about 30%, that's the fourth line, it suggests about the maximum impact of the hypertension. Fifth and sixth line again about the relatively high normal blood pressure. This is again based upon the statistics collected across. References are there in the baseline. Next part. Now, the other important issue is hypertension is considered to be a cause of the cardiovascular mortality, sudden death occurring due to incidence of cardiovascular pathology. Now, that possibility of cardiovascular pathology, having a cardiovascular pathology, still exists even if you consider the pressure as normal, 120 by 80. Now, this is about our latest guideline. That first line is the possibility of, statistical possibility of having a cardiovascular accident, a coronary accident, anytime, as per the normal, whereas the last line is about the stage 4, that's the highest of that blood pressure. Now, I will not bother about that part, is fine. If you compare the height of the columns of the first, second, third, the difference is virtually very minimal. And that difference is not statistically significant, though there is a difference. Now you can see, you can appreciate by the column. These columns are not drawn by me. I have collected from authentic sources. The sources are over there. Now this is about the total picture about why the hypertension needs to be considered. Hypertension is treated with an idea of preventing those complications like cerebrovascular accident. And in those categories which we call as the low and moderate hypertension conditions, that risk level is relatively very small, and that small difference, whether it needs all that attention or not. High category, fine, that very high pressure, terminal, third stage hypertension, the difference is quite significant, definitely yes, it needs to be prevented. Whereas with the other causes, whether we are really able to prevent that or not, that's one of the issues. Next, one more of the statistics. Now, I'm just giving you the statistics now because hypertension is abstract statistics. Don't think that it ends with the statistics alone. This is only a prelude. Now, another of the major complication of the hypertension is a multi-organ failure, end organ failure conditions. It could damage any other organ, not only the brain or the heart, eyes, kidneys, and so on. And that's we categorize as end organ failure conditions. In the end organ failure conditions also, the difference between a normal and high blood pressure incidences are not very huge when the blood pressure is within that moderate range. Now, 120, 80, 140, 90, that part I will not deal with now. We will come to that part later. But in the moderate. But when it is a very high pressure, of course, the difference is high. Next slide. Now, there is one more of a very important, a maximum number studied statistics. This is one of that maximum number of studied statistics. Is about the risks of, probably I think you will be able to read that. Fonts, I think you can see it from the distance also. The issue is that the columns, that the blue line suggests about the systolic blood pressure, diastolic blood pressure, and the red line is about the systolic blood pressure, and how the factors which can increase the blood pressure, and this is again studied throughout the span of years. The important is cholesterol, high density levels, smoking, and the other factors which can produce the hypertension. Now, important is, if you do not have those habits, like those habits are negative, then virtually you may not have a hypertension. Chances are that your systolic and diastolic pressure are normal. As the incidence increases, like smoking and the dietetic factors increase, which are actually precipitating the hypertension, the incidence of the hypertension increases. So, after all, The basic issue is hypertension is related to the diet and your habits like smoking, alcohol and so on. Many factors are identified. Next part. Now, this is another very interesting issue, a interesting study, which is again a huge study, comparatively huge study, which has studied the hypertension patients in India and in USA and the global. The blue line suggests about the global. The midline is about the India. Last line is about the USA studies. Interesting, and this is in a span of time. The first is 1960 and the last column is 2016, which has studied about the possible factors which have produced the hypertension in these three setups: total global average, India, and then USA statistics. And I will draw your attention to the last column. We will not waste much time on the other details. Like the last column, 2016 column, there the red color is higher, and that suggests about the dietetic factors which are still a cause for the hypertension. Whereas in USA, in the earlier stage, it's very interesting. USA in the earlier stage, 2016 conditions, the dietetic factors were more. Now they have studied, they have learned that, and the people now are getting into the dietetic factors, and it's regulated. It's not the drugs or medicines which are promoted over there. Whereas in India, the dietetic factors are still the most important factors which are producing the hypertension, and we are depending upon the drugs for controlling the hypertension. This is the controversial issue. Again, I will not go into all that details and threadbare discussion of that part, but we need to be aware of this issue also, and when we identify our role in the management of hypertension, all these factors count. Next part. Now, with the hypertension, again, lots of theories. Why the hypertension occurs? One of the most controversial and troublesome theory, I say troublesome because every time the picture changes, is the theory of dyslipidemia, abnormality of the fat metabolism being responsible for the hypertension. There again, the whole concepts have changed from 1980 to 2013. And the latest of the theory is it's only the low density lipids which are responsible for the hypertension, and there too we have LDL-C, another variety which can be identified as considered to be responsible for the hypertension. But this also is non-conclusive. Still a significant number of people who have a normal lipid levels, they have hypertension, they are having hypertension. A significant number of people who have an abnormally high lipid profile, they may not be hypertensive and they may not have any of the complications. The whole picture has been changed from a simple cholesterol to different varieties of the lipid throughout, and this also has produced some impact on the market. Now that part, a bit of that, I'll come to that later, about that impact of the market and then how we can make use of that issue. That's one of the most dependable theories of why the hypertension occurs. Next. Now, another is considered to be physical stress, psychological stress, or so on. And interesting is a study was done about the factors of stress as being a cause of hypertension. Generally, people would say, like those who have a short temper, and usually it comes like this: when a husband and wife comes to the clinic, husband asks the doctors to measure the pressure of the wife, or vice versa, and because they have some issue in the previous day, and they consider kopa jasti anta. So this is the general idea. But statistics has proved the other way. Persons with the short temper may not be having the hypertension, but those who are suppressing their emotions, they keep silent, they tend to have the hypertension more. Anyway, but this is not statistically significant. The other part, like how the statistics and mood issues, that part also I will try to refer to a bit more detail later. But this is about a stress being a cause of the hypertension. Of course, it's universally accepted, like lifestyle factors, and it's often said that hurry, curry, and so on, the other usual terms used, which are considered to be the cause of the hypertension and related. The hypertension is the beginning, then you have the atherosclerosis, cardiovascular accidents, and so on. So you'll have series of the complications which are occurring as such. That's another of the theory. One more of the theory, and quite important, and rather I would consider it's important, is the oxidative stress hypertension. Oxidative stress hypertension is the latest theory, and it's considered that during the metabolism, some free radicals are produced, and these free radicals, they are present in the body and they tend to produce the damage to the mucosal cells of the blood vessels, and then hence they produce the hypertension. This is considered also as a factor of the aging, that oxidants and free radicals is related to the aging. So hypertension in a sense is a sort of premature aging. When you age earlier, it could be the hypertension. In summary, without going into much of the technical details about that theory. Next part. So I will not go into the theory of hypertension. The other cause for the hypertension is a secondary hypertension, like a pathology of other organs, like kidney disorders or thyroid disorders, being the cause for the hypertension, where it's not the primary hypertension, and your target of the treatment there would be totally different. It's not only about the regulating the pressure. You need to consider those. They are considered as a secondary hypertension, and comparatively, secondary hypertension are very few. The major portion of the circle is the primary. Those small pieces of the pizza, that pieces of the pizza which you see over, they are the secondary. I will not go into all the details like which are those and so on. But the important is when a patient of hypertension comes in, you need to know like whether the other organs are damaged and whether it could be a cause for the hypertension or not. Secondary hypertension, the whole approach to the treatment will be different, and whatever we discuss as the management may not be applicable in that condition, and whereas our focus would be only on the primary hypertension as such. The next part. Now, secondary hypertension, among the secondary hypertension, one of the most important causes, as we see practically in the clinical field, is due to drugs, drug-related medicines. Drug in the sense not the addiction-forming drugs, drugs which are prescribed. And what we see in the regular clinical practice is estrogen drugs, then the illicit drug uses like cocaine and so on, then non-steroidal anti-inflammatory drugs, many of the psychiatric drugs, and many of the, of course, sympathomimetic drugs which are used in the respiratory disorders also are considered as a cause for the hypertension. Statistics says there are herbal drugs also which can increase the hypertension, and among the herbal drugs which are studied already, it's very interesting, is Lashuna. Lashuna is shown as a drug which produces hypertension. Licorice extract is also known to be inducing the hypertension, and in USA, licorice containing food substances are banned. That's a very interesting issue. The issue is because licorice or madhyasti extract, licoricic acid, is known to induce the hypertension, whereas madhyasti as such we use in the treatment of hypertension. That part I'll come to that part next. But that's about certain of the issues. So whenever we think of a secondary hypertension, it's not only about the organic damage. You need to have a detailed history of the medicines the patient is taking. And among the medicines which we see here, among our patients, the most common are the non-steroidal anti-inflammatory drugs. These are now being sold on the counter, and people are now having this as they use the salt in their food, they use these drugs quite frequently. And another, of course, the estrogen-containing drugs, which are also used for regulation of fertility. Now, that's the other part. Next slide. Now. Then there is another issue, the malignant hypertension, where the exact causes are not known, but all of a sudden the blood pressure shoots up and then produces the damage to the tissues, acute emergency conditions. Acute emergency is related to the malignant hypertension, which can produce retinal damage, myocardial pathology, and so on. Another area where we may have, I will not go into much of the detail, but a patient coming to you with a hypertension, you need to know like whether the patient is in that malignant stage or not. If the patient has a malignant hypertensive condition, it's an acute emergency which needs to be handled as early as possible. Time would be a very important factor. So that's all. Next now. Now, this is not a very important thing, but I have copied it from a popular blog site, WebMD, very popular blog site, which has given an idea of the causes of the hypertension. And among the different causes of the hypertension, number one is your doctor. That highlight is mine. of course, the 15 factors which are mentioned by the blog site, I have just copied it as such. Only the thing which I have stressed is your doctor. Now, I will not go into much of the detail like how a doctor can produce hypertension or not. It could be related to the bill. Now, the next one. Now, that's about certain of the simple issues, confusing issues, but I am not intending to confuse you, but I try to give you some clarity about that. Now, because the hypertension issue, what is considered as normal and so on, there is also a controversy about the management, like how to manage. Latest guideline, now I am not again going into all the details like which are the guidelines earlier and so on. The latest guideline in the management of hypertension, which is again drawn by the AHA only at the end, is this. Now, because the fonts are very small, I try to cut that guideline into two pieces. Next slide. Just one half of the same. I will stress upon only one part, like if a patient is having a normal blood pressure, now the guideline is you try to promote optimal lifestyle habits. You suggest about lifestyle habits, don't go into the medical treatment. It's all non-pharmacological treatment is suggested at that level. And in the elevated BP, that's in the current standard, when the blood pressure is in between 129 or the systolic pressure is 120 to 129, diastolic is at 80, lower than 80. There too, it's not non-pharmacological intervention is suggested. Recommendation is to use no drugs to be used. It's only the lifestyle. Only when you have a reassessed, and then after reassessment also the blood pressure doesn't come down, then you may think of the other regimes. Next part, the other half of that, next slide. The other half where stage 1 hypertension, where it's marked hypertension. In that condition too, pharmacological intervention is not recommended. Now, I stress upon these issues because we will have certain related issues discussed later. So, and there too, the first attempt is a non-pharmacological intervention. No medicines are prescribed. It's about the lifestyle, it's about the diet, exercise, and so on. So, all that role of yoga and so all that issues come in. The pharmacological intervention is limited only for the class 3 or stage 2 hypertension where the complications are there, or already the patient has developed the complications, or in third stage, that's malignant hypertension conditions, then a direct pharmacological intervention is suggested. Otherwise, the pharmacological intervention is not recommended by the global recommending committees. That's all the point. Next. Now, that's about the issues. Now, the best proven non-pharmacological intervention for the prevention of hypertension, this is again what the WHO has recommended, global recommendation of the WHO. That the first is about the exercise. Exercise is when you do a rigorous exercise, you expect the blood pressure to reduce by about 10 millimeters of mercury. Then there is a DSH diet against the hypertension, which is considered as universal. Again, I'll go into the detail of that diet which is suggested, and that can reduce again by around 11 millimeters of mercury. And then of course, solutions about the psychological stress and their issues, there again the optimal pressure can be reduced. So, non-pharmacological intervention after all relate to the diet, exercise, that's all about, and modification of the lifestyle where you regulate your time for sleep, regulate the time of rest and so on. That's recommended as the non-pharmacological intervention. Next slide. Diet which has to be avoided and the diet which can be recommended. Diet which has to be avoided, most of these diets are those which when you go back from the CME, have that ice cream and chicken. So I have targeted one person. No, the point is such of the spicy, sugar-containing, salt-containing diets, they are the ones which are known to increase the blood pressure. Again, I will not go into all the details. Next, the exact diet, dietary approach to stop hypertension, universally accepted. This is a global DSH or DASH diet is a universally accepted. Every nutritionalist now these days, the responsibility of the nutritionalist is increasing. Nutritionalists will speak about that issue quite significantly, and this contains only simple issues. You have to have grain and grain products, fruits, vegetables, and low-fat dairy products. Dairy products, it should be low-fat dairy products. And meat is not generally preferred, but when it is to be taken, then lean meats. Lean meats in the sense which do not contain much of the fat, which do not contain yellow as such. Nuts, seeds, legumes are to be given. Fats and sweets are allowed only 2 to 4 times per week and not more than that. That's how it has to be suggested as the DASH diet. And most of the times we do the ulta, the totally opposite. The fat and other fried substances are taken more, salt is taken more, sodium contents are taken more, and that could be the cause for the increase in the circulatory pressure, right? Next. So that's about bit of the introduction. Now I think I will not be able to cover up all the issues, but I have tried to pick up certain of the issues which would be important to come to our point, like how we can assess from the Ayurvedic point of view. From the Ayurvedic point of view, assess hypertension is another of the controversy. Sushruta or Charaka never had that sphygmomanometer, so quite natural that they would never be able to mention hypertension directly or such a situation. But that's not the issue. But diseases were existing. So I am very sure the diseases were identified and they had identified the disease and try to manage them. So that's all what we are trying to see, like what could be the management or what could be the identification of the disease by Charaka or Sushruta, and then how we can adapt to the present practice as such. Now, when you go into the Ayurvedic literature, so-called now, because we have plenty of Ayurvedic literature now about the hypertension, almost around 15 national level conferences were conducted in the Ayurvedic field about hypertension, and at the end there could not be any conclusion like what should be the name or what should be the identification of the disease of hypertension by Ayurvedic means. These are all the different varieties, different terms used by different committees or different authors, specialists as such. I'll come to my view, and again one more, that's at the end of that. Now next slide. Our Ayush department in its national health portal has given one full page article about Ayurvedic view of hypertension, and there it's named as Vyana Bala. And the next slide, they have suggested about the medicines also. Again, I am not criticizing or anything, but I think you should be aware of this, like what our the field is presented as such. These are the drugs which are presented. I think we are able to read that, and the important is, I hope we are able to read that, and the important is there is no specific like how much of the dose and so on. It's considered as if the treatment for 15 days or 1 month, the duration is 15 days or 1 month, that's the duration. It's presented as if the hypertension can be cured. So the issues related, the complex issues related to the hypertension are not discussed. It's named as Vyana Bala in that condition. Again, I will not say who is right or wrong, because that kind of an argument is not our topic. Our present issue is how we can manage with the hypertension in the clinical conditions. So now I'll go. Now this is a quotation from Asanga Sangraha, where the Pranamata is considered to be having a function of Dhamani Dharana, the sustenance of the circulatory vessels. So the function of maintenance of a healthy condition of the circulatory vessels is done by the Pranamata, and the functions of the Stira, according to Sushruta, Yabiri idam shariram aramaiva kulyabihi. Now, the idea of a blood circulation, now this is another of the important idea of a blood circulation, which we always attribute to William Harvey. It was described much earlier by Sushruta much efficiently. The functions of the circulation, like the fluid going into the tissues producing the nourishment, and the same fluid coming back, that's the aramaiva kulyabihi, like a garden being nourished by the water channels, or it could be like the sarita iva sagarayan iva, like streams of the vessels again coming back to the your river or the pond or so on. So a circular flow is already described in Ayurveda, but unfortunately we are not able to present globally, and whenever it comes to the question of identification circulation, the credit goes to Harvey. Again, I am not saying that the credit should not be given, but at the same time, the value of Sushruta also has to be highlighted wherever there is a opportunity, and I try to do that whenever I get the opportunity, and that's the important issue. And that Akunchana Prasaranadibihi Visheshahi, the pulsation occurring in the vessels also were identified by Sushruta, and they are described as one of the important functions of the siras. Next. Now, the Vagbhata Ashtanga Hridaya, it's mentioning about the exact functions of the circulatory conditions. Vyanena rasadaturuhi vikshepa uchita karmana. That uchita vikshepa karma is the real circulatory pressure. Uchita karma, what Vagbhata has said is an optimum pressure of the circulation is the function of, again, Vyanavata. So you have two important components from Ayurvedic point of view: the Pranavata, which is responsible for the Dhamani Dharana, the maintenance of the vessels, and the Vyanavata, which is responsible for the Vikshepochita Karma. So elasticity, and that's what we call as the peripheral resistance, and the hydrostatic pressure. These are the two important factors. If you study the hypertension from the physiological point of view, it's all the only two factors: the elasticity or resistance given by the vessels, and the hydrostatic pressure, the pressure which is exerted by the heart. These are the factors which produce the hypertension, and these are described in Ayurveda. Ayurveda has described about that in two different contexts, but it may not be exactly in the same terms, like the pressure and objective measurement of pressure, like so many millimeters of mercury and so on. These are not mentioned, but a value of that pressure and the abnormality which can be produced due to that variation in the pressure can also are mentioned as a kavaigunya. If there is an abnormality of a structure somewhere, a variation in the pressure and variation in the circulation can produce a disease at that level. Multi-organ failures, any organ could be involved. This is exactly what Ayurveda has said. So virtually, there is not much of a difference in the basic, it goes to the basic theory, but details, of course, you have more of details, you have more of statistical data, and I am not denying the value of those values are there, but at the same time, we should be proud of this heritage. And if you go into the history of hypertension in any, if you search for that historical facts about the hypertension, the credit is given to Egyptian history, where the Egyptian history says about rigid vessels and so on. I think we need to have some method by which whenever that history issue is recognized, the reference from Ayurveda also comes in, are seen globally. Now, whether this has a practical value or not, or what you are going to gain, these are all the secondary issues. But I think that records have to be put straight, like the facts about the circulatory conditions and a abnormality of the circulation were known in Ayurvedic point of view. Next. Now, the disease of hypertension. The disease of hypertension, I consider this as, it is purely my consideration, again it's always open for debate and controversy. In my practice and when I prescribe the medicines, when I select the medicines for the hypertension or manage the hypertension, I consider this as one of the variation of the Anyonyavarana. Prana and Vyana, when they have the Anyonyavarana, very obviously that should result in the hypertension conditions. The Vagbhata has clearly mentioned, like a Avrata Bhata can remain silent for many years and then may produce a Dustara Vyadhi. It could be like Jnataha Vatsaram Sitaha. It can remain silent for about a year and then it produces an incurable condition. Hypertension is a silent killer, that's the word which is used now. And Vagbhata has clearly mentioned a Avrata Bhata can remain silent without being recognized for a year and then it produces incurable disease. Is there any difference? It is exactly the same issue. Language is different, words are different. Then the complications which can occur due to the hypertension, Hridrogaha, the number one. Cardiovascular pathologies we consider as one of the major complications of the hypertension. Then Vidratippliha Gulmatisaraha Bhontipadraha Tesham Avrtayana Upekshanata. Due to the Upekshana, not recognizing and managing these Avaranamatas, you can produce these complications. And hence, I consider what Vagbhata has, Tasmat Avaranam Vaidyaha Pavanasya Upalakshayat. So I say, I consider as the complications of Avarana Vata, hypertension, I consider as the complications of the Avarta Vata. So, now how to manage, and now we have to relate it to what we see in the present day's practice. Now this is about rough, again, that percentage which I have shown in that table is not an exact percentage, a rough average percentage of variety of the patients who come to us. We are living in the present day situation, and many of those facts cannot be negated. So rarely we get a few of the patients who are newly diagnosed by us as a hypertension. Majority of the patients are already diagnosed as hypertension and they have either treatment. There are certain patients who are diagnosed as hypertension by somebody else, but they will have some soda bottle impression, like soda bottle the emotion. They come to Ayurveda. So you will get a few of that patients of that category. So now I discuss this issue because we need to have a strategy which would be suitable to each of these contexts, and that's why I analyze this, what we see. And then there are many of the patients who are already on antihypertensive drugs and they are stable, they are normal otherwise, but occasionally they say that I try to switch over from a contemporary medicine to the Ayurvedic medicine, and there are a few of that patients. And then a few of the patients who are having antihypertensive, but they are not stabilized. They still have the hypertension, they are taking hypertensives, and they say that whether Ayurvedic medicine can help them or not. That would be another category of the patients. And then patients who are already on antihypertensive drugs, but they are coming to you for some other treatment. May not be about that, usually arthritis and so on. So it may not be of that category. That's another of the conditions. Then rarely are very few of the patients who come with acute complications like cerebrovascular accidents. Of course, in our hospital, we get more of the patients with that acute cerebrovascular accidents now. But otherwise, in a general Ayurvedic practice, they would be lesser. And patients with having secondary hypertension, they are also comparatively lesser in our practice, in my practice. Now I say it's in my practice. This is roughly about, it's not a very perfect data, roughly about the percentage variety of these patients whom I get. Now how I strategize. Next, my strategies are, now in the few of the patients, like in acute end organ failure, patients who come with the acute end organ failure like a CVA, where the time factor is an important factor, I consider as there is a limitation for Ayurvedic treatment. I don't depend upon only Ayurvedic management. There it depends like whether the patient accepts or not. We need some other immediate emergency management. Later, once the patient's condition is stabilized, then we may have our management. So that's part where we do not have a definite strategy, and the strategy is to ensure that the patient's life is saved and the damage to the organs are minimized, because after all, a patient coming to the cerebrovascular accident, even a few minutes of time has a significance, and you have standard protocols of managing that condition and save the life of the patient, and that should be utilized. So I do not give much of a role, I don't consider that there is a much of a role with our treatment. So my point of view, I do not have much of a role, but I do give the medicines, but the primary core part of the treatment would be the other way. Then you have the patients who are on antihypertensive drugs with the stabilized status. Already they are stable, otherwise they do not have any pathology. But all of a sudden they would have an emotion about Ayurveda and they come to me. I always suggest like you continue the same treatment. The reasons are simple. Most of the times they may not have the same patients continued for a longer duration. That's what I say, soda bottle. Or they may not be so regular with our medicines. Whereas the other antihypertensive drugs, they are easily available, so they can sustain with that treatment easily. So I try to avoid them, but if the patients insist, then we'll have a treatment. I will be recommending the treatment. That part I will come to that. Please, the last part. The on antihypertensive but not stabilized, but with the complications as such, my idea is to maintain the existing regime. I will not stop those antihypertensive drugs. Along with that, we may plan our management and co-prescription of our drugs. I have prescribed our drugs along with other antihypertensive drugs in large number of patients. I have not come across any complications till now. So we can freely co-prescribe the drugs with other drugs as such. That's all the confidence which I have. That's the point. Now next part. Now in the other conditions, now other areas, and these are certain of the areas which I consider as some reservations. The other conditions where we have to consider the hypertension and management. What I have found is patients with a symptom related to hypertension, they are relatively easy to be managed, whereas a patients who are asymptomatic, there the response with our drugs are comparatively lesser. So asymptomatic patients, where the patients do not have any symptom but they have a recorded high pressure, that's the point where you have a real problem. Now I categorize the patients of symptoms of hypertension into the first category is Udanavrta Prana. Now, Anyonya of all Vatas also are to be considered as hypertensive. So, in the Udanavrta Prana, the features are Nishwasa, Uchchasa, Samrodha, breathlessness. And many of the patients of hypertension coming with that dyspnea on exercise, or they have a cardiac enlargement. Now, about the cardiac enlargement also is another issue. In 2014 guideline, the previous guideline of hypertension and identification of hypertension, to confirm whether a patient needs a treatment or not, one of the criteria was the thickness of the ventricular wall. Echocardiography, if the thickness of the ventricular wall is more than 10 millimeters of mercury, whether the patient's circulatory pressure is more or not, he needs some supportive treatment because already there is a load on the heart. That's the condition. Of course, in the 2017 guideline, that part is removed. Again, I will come back to that issue also as a controversy. Now, anyway, so such of the conditions I consider them as Udanavrta Prana, and in that condition, my prescription would be Chandraprabha Punarna Mandura Avipatikara Churna. The responses are usually good, but at times inconsistent, not very consistent. Some of the patients, they show a very good response. Some of the patients do not show very satisfactory response. Patients who have already have a significant cardiomegaly, the responses are poor. If the cardiac thickness, ventricular thickness is not much high, then, and of course, the other part, lifestyle, diet. These are very important. Lifestyle, wherever possible, I recommend the patients to undergo yoga, and yoga and exercises have a very significant role to play, and in this category of the patients that still has a more value. Diet and the other parts of the lifestyle, they are also important in the management. So it's not only about the drugs which are prescribed, but this is my prescription in case of Udanavrta Prana, Anulomana Drag Avipatikara, and Chandraprabha Rasayana. Now, another, in general, all hypertension conditions I consider as a Jara Vyadhi, because as I said, it's a signs of aging, the stress, the oxidants and the oxidant-induced damage is the Jara Vyadhi. So one Rasayana Aushadhi is always preferable. So I prescribe Chandraprabha as a Rasayana in all hypertensive conditions as such. So Anulomana is the other part of the treatment, and Mutrala Aushadhi like Punarna Mandura is also the other part of the treatment. Next, now another category of the patients who present with the hypertension is the Pittavrta Prana or Pittavrta Udana. Pittavrta Prana or Udana. In both these conditions, this symptom will be giddiness as a symptom. That's again common. Among the hypertensive patients, this is the most common kind of symptom which you come across, which is involvement of suggestion of the Pitta as such. And the features are Brahmo, Murcha, Rujadaha. This is again exactly described by our text as such. Or it's also Antar Urja Bhramsha, Antar Urja Bhramsha, Agnimandya as a symptom of the hypertension also are seen, and in that condition my treatment is usually Chandraprabha Kamaduga Bunimbadi, targeting about the Pitta involvement, Chandraprabha as a Rasayana. And these category of the patients, they respond very well to Virechana. In the first category, Virechana, I do have prescription of the Virechana, but the Virechana may not have a very consistent results. Whereas the category of the patients who present with the giddiness, and up to the second degree of hypertension, I am not suggesting about the third stage of hypertension. So within that range of which we can manage, this kind of prescription gives a good response. Duration of the treatment, again, it depends upon the patient's status response as such. And Virechana, frequent Virechana, often can help in a complete resolution where the patient can live without any medicines also in this category. So Virechana is Virechana in the sense Karma Prakar Virechana, where you give the Snehana and all that protocols of Virechana. Samsarjana Karma followed after the Virechana also are quite important there, and with that the patients would have a very significant response. Next, Next category of the patients are the Pitta or the Vyana condition, where the patient would have the generalized symptoms, where the patient may have temporary weakness in the body. So, Klamaha Angachestasangascha. Angachestasanga is the transient ischemic attacks. This also is another very frequent clinical symptoms of the patients of hypertension. And often, many times, we tend to get awed by, patients are awed by that kind of a symptom as such. Transient ischemic attack is totally different from a cerebrovascular accident, where the patient may have a numbness or loss of movement temporarily for a few hours or few minutes, and when the patient doesn't recover up to after 15 minutes, then only we consider of a cerebrovascular pathology. Till then it's a transient ischemic attack, and those who tend to have these kinds of attacks of less than 15 minutes, they are very frequent. Many times they are not reported by the patient unless you ask some specific question. And these are the patients where my prescription would be Chandraprabha, Ekangavira, Manjashraji or Ashwagandha, depends upon the other conditions of the patient. If the patient is otherwise physically weak, then I would prescribe Ashwagandha. Otherwise, the general prescription would be Manjashraji, again considering that Pitta as the compound. The other treatment which I usually prescribe is Matra Basti or Rajayapan Basti. This also is depending upon the patient's condition. Patient who is emaciated or physically weak, the ischemic neurological deficit seem to be persisting, then I prefer Rajayapan Basti. If it is the other way, the Matra Basti is prescribed, and there too we can have a significant satisfactory outcome. I am not saying that every patient of that category can be cured with only our medicine. There are certain limitations, and that limitations have to be identified only by follow-up. There is no other way of identifying those limitations prior to that. Next part. Next slide. Now, the other variety of the hypertension which we come across are the obese patients. Obese patients where it's due to the Kapha Vrata Vyana Lakshanas. Kapha Vrata Vyana Lakshana is Kapha Vrata Udana Lakshana is Udane Gurugatratvam Aruchihi Vakswaragraha. Exact the same symptom like hypertension accompanied with obesity. The only point is we now often consider obesity as a cause of the hypertension, whereas the statement says the obesity may be also a result of the pathology. Now, we will not go into that issue like which is true or not. Or it could also be involvement of a Vyanavarta Prana, where the same issues like Guruta Angeshu Sarveshu Skhalitam Jagato, a very beautiful description of the clinical symptom, Gatau Skhalitam, where the patient may not be able to walk freely, his gait seems to be impaired due to the Guru Gatratva, due to the obesity. In these conditions, again, my prescription there would be Chandraprabha Arogyavardhini and the Avipattikara Churna, considering that Agnimandya and the Anulomana as the major target of the treatment. I usually prescribe Agni Chikitsa and Ksharabasti in our hospital after admitting the patient, either Ksharabasti or Matrabasti. Ksharabasti in the patients who are more obese, Matrabasti moderately obese. So when the patients have more of that Kapha Lakshanas, Tikshna Pachana Aushadhi, Agni Chikitsa is a Pachana Aushadhi which we prescribe in our hospital, and this could be the usual line of the treatment, which also gives a significant satisfactory result. Again, none of the conditions, none of the prescriptions, I cannot claim that every patient can be managed successfully. So it always has to be a case-specific approach. There are still a good number of patients who may not respond to these treatments, and you may need to think of some alternative. Causes may be many. Reasons may be that patient may not be following the diet, patient may not be following our advice about the exercise and so on. So that's another part. But from the clinical management point of view, I don't consider these as a foolproof prescriptions. So let me be very clear, like these are not foolproof prescriptions. There are limitations, and those limitations always have to be carefully watched out. Next, now the other complications, hypertensive encephalopathy, the conditions which are seen, they are described in our text. That's all. Ayurvedic texts, they have mentioned that in the context of Mada Vyadhi, the complications which can occur, Yadatu Raktabahini, Rasasanya Vahanicha, Pritak Samasta, Srudansi Kupita Malaha. In that condition, the typical clinical symptom are Mano Vishobhayam Jantoho, Sanyam Samohetada, the Samnya Samoha, impaired consciousness, and the abnormality of behavioral abnormalities. These are the typical conditions of hypertensive encephalopathy, which are considered as asadhya by Sushruta. Sushruta has considered that asadhya, Charaka also has considered as asadhya. Next part. Now, in that condition, my management would be again case specific, and many a times I try to maintain the blood pressure. So this is my prescription. I try to ensure that the blood pressure is stabilized by other established antihypertensive regimes. I will not go into the detail like which of the drug to be prescribed and so on. So I do prescribe. So I am not a pure Ayurvedist from that point of view, because at that time the issue is about saving the life of the patient and time duration. But compared, if necessary, life support. If at all the patient has a problem with the supporting the vital functions, a life support SOS like oxygen and so on, depending upon the status of the patient. But the other common prescription which I usually give is Chandraprabha Ekangavira, Abrakavasma Tapyadi Godantyapatikara. Abrakavasma Tapyadi considered as the regime of treatment for Dhatukshaya and the Margavarana. Now both Dhatukshaya and Margavarana needs to be treated. That's what I prescribe. And with this, patients would have a better recovery. Encephalopathy patients, they tend to recover better when we prescribe our drugs along with the standard antihypertensive regime. So I don't say that I am managing the hypertensive encephalopathy only with our drugs, but when it is prescribed with other drugs, it helps. And Agni Chikitsa and Matra Basti, which is again standard protocol in our hospital in majority of the patients. And a good number of patients have recognized this, and number of patients who come with that acute presentation to our hospital is gradually increasing. Earlier it was like patients of stroke, after having the treatment in other hospitals, they come to the Ayurvedic hospital only at the end for massage and so on. But the trend is gradually changing, and that trend changing is because of this kind of the approach. That's what I say, what I feel. Now next, now that's one area. Now another area where we can have is, you will have patients with the significant number of hypertension complications. Patients who have the drugs, antihypertensive drugs, and they tend to develop the complications, and the patients come to us for the management where either these complications either are not recognized or they are not managed properly. There are some areas where definitely we can produce some change without modifying the antihypertensive drugs. Among them, just one strike. Now you have this. First of the condition, the beta blockers. Beta blockers, often they produce the breathlessness. There are two important complications with the beta blockers. I will not go into those issue of the details, but from our clinical management point of view, these we have to know. One is they tend to produce the bronchoconstriction, aggravate the bronchoconstriction. I don't say produce, correction. They aggravate the bronchoconstriction. So patients who have a bronchoconstriction, they tend to have an aggravation of the conditions, and in that condition, my prescription would be Chandraprabha and Shwasakuthara. Another important issue is patients with the beta blockers, they have a reduced compliance of the cardiovascular system, and if you do not advise a restriction of the exercise, that limit of the exercise is not followed, they have a high risk of going into collapse. So every patient with the beta blocker should be recommended about the limits of the exercise which you can do. If the patient goes beyond a limit, patient heart would not be able to respond to the increased demand of the blood. So in a normal person, when you do more exercise, naturally heart beats more and then more blood is pumped in, so that you can cope up with that increased demand. Whereas under the beta blockers, this effect is reduced, and that can produce the complications, and hence you have to be advising that. Of course, there is no other medical regime. It's about the regulation of the exercises. Then the next, the alpha blockers are rarely prescribed, and most of the times you don't get that as a common this issue. Calcium channel blockers, these are another commonly prescribed drugs here in majority of our patients, in majority of the cardiologists around. One of the common prescription is calcium channel blockers, and in that condition the most complication is about the rhythm abnormality, bradycardia, or a significant hypotension. These are the major complications. There can be a significant fall in the blood pressure. Such conditions, of course, we may not withdraw that. Calcium, many a times a patient who has already a complicated cerebrovascular accident or coronary pathology, a withdrawal of the drug is virtually not possible. In that condition, administration of Prabhakaravati can give you a significant result in the outcome, like patient can feel better, and that can be one of the areas where we can definitely produce some change there. Next, AC inhibitors are the other drugs where you will have often angioedema, allergic reactions, and hepatic pathologies. I consider this as Shita Pitta. Arogyavardhini or Manjastadi, Arogyavardhini, the Manjastadi is the usual prescription which reduces that complication. Next, the angiotensin receptor blocker drugs also are the other conditions which can often produce a postural hypotension conditions, and in that condition the usual prescription would be Chandraprabha and Saraswatarista. The anxiety, neurosis and giddiness kind of the symptoms, they tend to occur. That's about the issues which we can manage. Next, of course, that's about my approach to the treatment. Now, certain of the other controversial issues about the hypertension, again, I will not waste much of the time, but I think I felt like I should be discussing those issues, otherwise the discussion would not seem to be complete. The major issues are sarpagandha and hypertension. Then, what is the ideal target pressure which you have to consider? Essential or primary, this is another very high technical issue. Dyslipidemia and hypertension issues. Hypertension in a short-tempered behavior, again I will come to that part, and herbal drugs as antioxidants. These are certain of the issues I try to at least present, sensitize you. We will not be able to go into all the details and all the broad views of these issues, but I try to sensitize about these issues from the general clinical practice point of view. The next first part, sarpagandha, I think all our Ayurvedic doctors are always very proud of sarpagandha as antihypertensive drugs, and probably it's only me who doesn't prescribe the sarpagandha as a prescription for hypertension. Sorry for all that being something like a outcast, but I have my reservations. The reservation is riserpin identified as a antihypertensive alkaloid of hypertension was in 1951. And it's not only the reserpin which is present in the sarpagandha, you will have many other alkaloids, and among them the scolarpin, which is one of the alkaloid in that hypertension, the sarpagandha, is hypertensive. It increases the pressure. So when you administer sarpagandha as a whole, you will be prescribing both reserpin as well as its antagonist. It's an advantage, disadvantage, both. So I will not go into that part, whether it is a disadvantage or advantage, but that's one of the issues. Next, sarpagandha in our text is described in the treatment of Vishachikitsa and Bhutabishanda. It's not in the Avrtavata conditions. Then the multiple alkaloids, when you are administering them, because now again the issue is sarpagandha being used in the hypertension is only after reserpin was invented. Till reserpin was invented, Ayurvedic doctors were not aware of sarpagandha being an antihypertensive drug. So if we are selecting sarpagandha for, prescribing sarpagandha for the reserpin, I would say reserpin is better where you know exact standard, like how much of the reserpin is given, whereas when you give crude sarpagandha, we do not know exactly how much of the reserpin is there and how much is administered. These are the issues which I consider. Again, I will not go into the debate, and when I say that I am not criticizing those who are prescribing sarpagandha, so it's not, don't consider it that way at all. Then the other important issue is the adverse effects. I have earlier in my practice, I have prescribed sarpagandha in a few patients, and I felt that it produces a common adverse effect. One of the common adverse effect which I see is a gastrointestinal tract abnormality. Sarpagandha tablets, they reduce the appetite. Typical Agni-Mandya Lakshanas are produced. And after observing this in a huge number of patients, I have stopped prescribing sarpagandha. So from my point of view, I don't consider sarpagandha as a treatment for hypertension. But again, I repeat that this is not a criticism on others who are prescribing sarpagandha. Still, that has its own significance. I am just giving you my view only. Now, next part. The other part is the target pressure. Now, this is another controversial issue. How much of the pressure is the target pressure when a patient comes to with a hypertension? Now, about the normal 120/80, which is considered by the our guidelines, is another issue. A patient who had a hypertension earlier, if you go on reducing the pressure, what happens? This is the latest data, 2017 released data, which has identified a new phenomena called as J curve. J curve is if the pressure gets reduced, the first column is the diastolic pressure, the next column is the systolic blood pressure. When it reduces, diastolic pressure goes less than 60 or the systolic pressure goes less than 130, in a patient of hypertension after your management, the complications which can be produced due to the hypertension raise almost equally as that of the possible complications which can be produced due to the hypertension. Now, I think you can make out that column, that graph. The graph, that checkered line, blue color checkered line, is the range of blood pressure, which is considered as statistically stable. Statistically, the risks are reduced. When the pressure goes beyond that higher level, it increases the risks of complication. But it's not only in the increased raise, the other side, the curve of the graph almost raises more acutely when the pressure reduces beyond that limit. So, over-treating of hypertension, a patient of hypertension where the end result of the pressure is lower, you are increasing the risk, or the whole target, your aim of the treatment of hypertension is to prevent the complications, and that purpose is not served. Now, this is about patients who do not have a complication. Now, this is about only those patients who have a primary hypertension where there are no organic damage. Patients who have an organic damage already, the whole issue is somewhat different, where you cannot apply the same formula rigidly, but in other conditions, this is one of the important issues. So, next. And hence this also another statistics now and this is another later statistics, where again when the pressure goes lesser than that, the lesser than 120 by 80, the percentage of the risk would be higher as such. The death rate per 1000 patients per year, it increases statistically. This is about the global statistics which are produced. It's not only my view, and hence one of the important issues which we have to be careful when we treat the hypertension conditions, that over-treatment should be avoided. Next part. So, the target pressure. Now, target pressure which I consider in my practice is always as 90 millimeters of mercury as the diastolic pressure, 150 millimeters of mercury as the systolic pressure. So, I consider that as a safe limit in a patient who had a hypertension and who is on medical treatment, and if I can maintain the pressure considering our clinical conditions. That's when I record the pressure in my clinic, definitely I will be adding a bit part of that white coat hypertension, which is not objectively measured. So, a standard protocol of recording the blood pressure thrice would be practically impossible in our clinical conditions. So, I consider 150 by 90 as the target value. If the patient is within that limit, in the clinic, when I measure the blood pressure with all that, my white coat and so on, I consider that as a safe blood pressure, and I think, though I do not have a very objective statistical incidence of the complications in my patients, I feel it's not much. It's almost at the same level of any other this hypertension management as such. The standards which are now prescribed, the latest again, universally also, these issues are now considered, and the target pressures in the patients having the known pathology. Patients above 60 years less than 60 years and without diabetes or renal disorder, the target pressure is diastolic 90 millimeters mercury is the target given by the recommendations for the hypertension by the 2014 guidelines. The 2014 guidelines, and I have quoted it from the global standards as such. If the age is above 60 or 60 as such, then the systolic pressure of 150 millimeters or diastolic pressure of 90 millimeters is considered as the normal. So, when I say 150 by 90 as universal for all, if you go into more detail, you have a few categorization there. All adults with the diabetes and chronic failure, again 140 by 90 is considered as the target value. This is the target value of the blood pressure when you treat the hypertension, and it is not the 120 by 80 which is considered as normal is the target value. So, that's about the whole issue of confusion and the need for all that prelude which we have considered. Now, the next part. Again, it's not a criticism on any other part. This is from a survey by Associations of Physicians of India, API, has taken a survey, and based upon that, in 2005, now this survey was done in, 2015, this survey was done, and that survey, again I will not go into all the details because my job is not to criticize on others, but when you treat the patients, should be aware of this issue. It's quite natural that most of our patients are over-treated. The issue is, in that survey, again, it's a very, publication is quite huge, you have the reference of the publication. I am taking up only two of the questions. One of the question is, what's the value of the blood pressure above which you would consider starting an antihypertensive drug, which is even asked, inquired with the different category of the physicians, cardiologists and so on. The important is 60% of the people, practitioners, and 60 plus 70% of the practitioners, they said that they would readily start the pharmacological drugs for the treatment of hypertension when the pressure is 140/90. This is not really the universal guideline. The universal contemporary guideline, I think what I have referred to earlier, is you need to have a non-pharmacological intervention, trial with a non-pharmacological intervention for a reasonable time, and then start with the antihypertensive drugs. So very obviously, majority of our patients who at the end, when they come to us also, very obviously, there are many patients who are unnecessarily prescribed with the antihypertensive drugs. That's one point, number one. Next part. Now, another question in that survey is about whether the patients, once the patient has an antihypertensive drug, whether the patient needs to be given the antihypertensive drugs for the whole life or not. There again, family physicians, cardiologists and physicians, they had a different sort of opinion. But those who said like the antihypertensive drugs need to be continued for the whole life would be quite significant, which is also not true. This is also not true, but this kind of practice exists. Now, again, it's not a criticism on the other practice, but the other point, but from a patient, when he comes to us, we need to have these issues. We have to consider, it's not necessary that the patients need to continue the antihypertensive drugs for the whole life. Definitely, the medicines can be discontinued. Pharmacological intervention can be discontinued if there is a regular monitoring and maybe with a supportive treatment. So, when we start with the Ayurvedic treatment and then manage the patients of hypertension, I do consider this issue. If a patient has already an organic damage like a cerebrovascular accident or a coronary pathology, I may not discontinue the antihypertensive drugs because that even slight fluctuation can result in more complications. But you have a good number of patients who do not have those complications. They come to with this hypertension. Definitely, I do consider a discontinuation of those antihypertensive drugs if the patients are ready for regular follow-up and then observation. If the patients are not ready for follow-up, then I will not take the risk. This is what I say. And you will have a good number of patients where we can have this kind of a advantage given to the patient. Again, all this, it's not a criticism on the existing practice, but it's about the facts which are existing in the practice and how we can have some change in the outlook of the practice. That's one part. Then the next part is about the essential hypertension word. Now, essential hypertension was a word which we used to study earlier, but now since 2014, the guidelines have removed that word. They do not use that essential because they do not consider that hypertension as an essential factor. But you will have a good number of patients who have a significant higher, maybe category 2 blood pressure, 150/90 or occasionally even 150/100. But once the pressure is reduced even by 10 millimeters of mercury, they will feel lots of giddiness, they will be feeling uncomfortable. So this is one of the area, and most of the times such patients one or other day, they come to an Ayurvedic doctor for the opinion. They will have that kind of a version. And maybe number may be lesser. It's not that they have a huge number, but this is one of the issue. And very often you will have that question like whether the patient with a high pressure requires a treatment or not. Now this is a point which I just referred to earlier also. In the 2013 guidelines, one of the criteria to start the antihypertensive drug was considered as the left ventricular hypertrophy. But now that guideline is removed. 2017 guideline is removed. So it's not only me who cries foul about that. There are many other doctors also who are criticizing that kind of a withdrawal from the guideline. But I still consider this guideline as a useful guideline. So whenever you have such a controversy, whether the patient requires antihypertensive drug or not, I follow this guideline. I refer the patient for echocardiography, and if the echocardiography has shown a significant evidence of the backlog in the ventricles, then only I would recommend the patient to continue with the treatment. Now again, whether my treatment or modern treatment existing, that's exactly the strategies which I have suggested earlier. But if the patient doesn't have a significant hypertrophy, then I would recommend the patient not to go for any medical treatment. Of course, the lifestyle, dietary factors, they are the important issues. They are advised, and a regular monitoring would help. And many of such patients, we can have a normal leading life where the patient doesn't have to take the medicines. Taking the medicines every day makes the patient feel ill, and that's what we can contribute to the patient from that point of view, right? That's one of the role. Then another of the controversial, again, very highly debated issue and very popular issue is cholesterol. And the familial hypercholesterolemia is one of the frequently identified condition, and the incidence here is considered to be more. So there are many people who have a normal diet where there is virtually fat content in the diet is lesser, but still the cholesterol level is more, and that's considered as a familial cholesterolemia, which was identified which was named, branded in 2011. So a very young disease. And this is another of the category where the patients would be prescribed lots of medicines. Again, I repeat the same, it's not about the criticism, but trying get an opportunity for us in the management. Now, next. The familial hypercholesterolemia incidence also is supposed to be very high in eastern countries. In India, that first column is about the India, the incidence is very high compared to others. Next part. Now, the complications, association of the cholesterol with the complications like coronary pathology, the death rate per 1,000 persons a year, it's important. The death rate in the younger age of less than 60 is not significant. The death rate is less than 50, it's not significant. The death rate increases rapidly after the age of 60 if the cholesterol level is more. You will have a good number of patients in the young age, teens, 15, 16, having the cholesterol, and then they are being prescribed with the drugs. Now, again, I am not going to the next slide. The criticism issues, but there are certain facts which we need to consider as such. People were aware of this awareness about the cholesterol also is increasing. And again, I will not go into why or so on. People having an awareness of the cholesterol is increasing very rapidly. More than 17% of the population, they are known to be aware of the cholesterol level and bothered about the cholesterol level, and many times they will be more sensitive about that cholesterol level than the doctors. Cholesterol, they use some special pronunciation there. The issue is about the prescription. Now, again, I will not go into all the controversial, but at times I cannot avoid that. The earlier prescription for this hypercholesterolemia was clofebrate. Now, statins were invented in 2008 and 9, their FDA approval, and then the statins are prescribed for cholesterol. These days, almost every patient who has visited or maybe has gone the road of a cardiologist practitioner, he would have a statin prescription, whether he has visited or not. So it's considered to be a universal health improver, and it's practically promoted in such a way that many of the doctors have got Benz cars, Audi cars for prescribing statins, no more than. Now, that's about the statin and the tendency for prescribing the statins. The column, that's about the years. Statins are over-prescribed and prescribed so rapidly, the prescription of the statins are increasing rapidly. Again, I am not criticizing whether the statins are necessary or not, but we have an advantage. Next, statins have a very common adverse effect, and that adverse effect is damage to the skeletal muscles. And the patients would have a pain in the muscles, very common, and it's not really arthritis pain, but the patient would continue to have that pain in the bones, muscles, and so on, vague symptoms, and most of the times the patients are sent for investigation of vitamin D3, and this has again a fad. Now, there is a linkage, cholesterol, statins, vitamin D3, which is a common prescription and which is a common investigation. Vitamin D3 investigation again costs quite a huge sum, and you will get a kickback also. And then the prescription there. This is the whole vicious cycle, and most of the patients, such of that category of the patients, they will end up in Ayurvedic hospital, Ayurvedic doctor, because general feeling is in the patients is for the pain and that neurological conditions, Ayurvedic treatment is better. So they end up in Ayurvedic hospital. So that's one of the fertile area for Ayurvedic practitioners. Statin-induced complications. And simple clue to identify exactly the statin level is, if you assess CPK level, creatine phosphokinase level, it would be at the range of 100 to 200. Not very high, not considered to be a sign of myopathy, but just above normal. If we have that kind of a result in any CPK level, creatine phosphokinase level, I don't have to ask the question like whether the patient is taking statin or not. 100% sure the patient would be taking statin. And the different statins, again, you will have plenty of that statins also. Now, that all depend upon your level. You have a Shahi Chikitsa, and common men's Shahi Chikitsa costly, and cheaper varieties. Now, again, I will not go into that part. But the part is, such patients having that statin-induced complications, they will be responding very well with our prescriptions. One, Chandraprabha Arogyavardhini Kumari Asava, it can produce a significant change in the lipid profile. So statins can be withdrawn, and we can replace with this kind of the treatment a significant number of patients of familial hypercholesterolemia. I am suggesting about familial hypercholesterolemia, not about the dietary issues. Dietary hypercholesterolemia is one component. Familial hypercholesterolemia patients, they can be managed with a significant value with our drugs as such. Then the diet and exercise is very supreme. That's the important thing. Then our medicines. Virechana also has shown to produce a significant results. Next part, with the adverse effects of the statins, again, with all that, you have a listed adverse effect. The most important is the myopathy, where the muscle aches and the rhabdomyolysis is the one area. Just one hit like. And, statin, we'll skip that slide. You skip that. Statin-induced myopathy incidence, statistics again. But the management in that condition, you have a very super hit treatment. Invariably a hit treatment where you never fail is Kaishara Gugul Mrutyunjaya Amritarishta. I consider that statin-induced myopathy as a Amavata, and my prescription is for the AMA. So my treatment for the rheumatoid pathology as well as the statin-induced myopathy is the same, Kaishara Gugul Mrutyunjaya Amritarishta. And as far as I remember, I have not failed in any of the prescription of that in case of statin-induced myopathies. And my internees or my students who are in the OPD, they are always fed up with writing this Kaishara Mrutyunjaya Amritarishta. They think of having a seal and then press it. The reason is that that's a very frequent prescription which I prescribe. Reason is simple. You will have plenty of patients who are taking statin. Now, that one part, like whether the statin needs to be withdrawn or not, that depends upon the patient's preference. Some of the patients may not prefer, some patients may prefer. It can be withdrawn. But if the patient is needing the statins and they need to be continued, and they come with that myopathy symptoms, definitely this is one of the treatment where we can have a definite better edge than any other treatment. None of that, vitamin D3 supplement or not even any other analgesics or any other standard protocol of the treatment, that doesn't produce such a satisfactory result. So this condition is, I say, with high confidence, unlike our prescription for the hypertension. So with the hypertension-induced issues, that's one of the issues. Next. Now, the other part, hypertension and personality traits. I think I just referred to that issue, stress as a factor. Now, personality traits and hypertension, elaborate studies are done, and it's now confirmed that it's not about the aggressive personality which is responsible for the hypertension. Rather, it is the introvert personality who tends to have the hypertension. Those who do not express much, those who keep silent, those who do not express their emotions, they tend to have more of hypertension than who tend to expose their emotions. That's the one part, which is generally the people perceive the other way. That's one part. Next, That doesn't mean that your short tempers do not increase the pressure. When you become angry, naturally the pressure increases, but that's only a temporary issue, and whether that temporary issue produces the change or not is the other issue. But you will have plenty of patients with the psychiatric disturbances, particularly depressive symptoms, because of the antihypertensive drugs. And among them, monotherapy, single drugs, calcium channel blocker drugs are known to have the maximum incidence of these depression conditions. This is again from the data available, not my data. The maximum number of patients with the calcium channel blocker drugs, they are known to have for the complications for mood disorders. And many times you will come across such patients who will have a mood disorder, they will have antihypertensive drugs, and the mood disorder somewhat, maybe, though not very objectively, can be correlated with that. In that condition, my prescription would be co-prescription. Maybe if there is a need for antihypertensive drug to be continued, I prescribe this, continue the same. With that, I prescribe Saraswatarista and Smritisagarasa, usually Medhya Aushadhis, with that idea, and that helps a lot. That reduces those complications as such. That's another of the avenue where we can have an impact in the area of hypertension. Next. Then another area is antioxidants, which has become a craze of the day. Antioxidants, lots of drugs are considered to be antioxidants, and lots of researchers are antioxidants, and very often our Ayurvedic people have a general trend to recognize many of our drugs as antioxidants. Researches are being done, I am not criticizing that part, but they are not very much objective issues. The best of the antioxidant, according to me, is a peace of mind. When you do not harm others, when you are in a pleasant mood, when you do not think of unnecessary issues, definitely that would be the best of the antioxidant. As far as the diet, and next slide, lots of literature is there. Maybe one of the standard book, which I consider as a standard, is this Lloyd's book, a very elaborate book, where many of the dietary substances which are used in our day-to-day factors and their antioxidant properties are studied in detail. So I will not go into the detail. With this, that's about the hypertension issues. I think when we thought of the Rasavaha Srotas, Hridroga was to be considered. I think we have crossed the time limit. I think I stop here only. Hridroga and related issues, maybe we may continue on some other day. Hypotension is a myth, virtually. There is no such disease like a hypotension other than that of acute circulatory abnormalities. Acute circulatory abnormalities like a shock, that's another issue. Shock is a different issue. But low blood pressure, now again, I will not use the word hypertension because colloquially low BP. Low BP has become another fad now, many people, but most of the times that so-called low BP patients would have some psychiatric disturbances, personality disorders like depression, and that depression is identified as low BP. And most of those low BP category patients who are identified by, again, some practitioners, they have only 120 by 80 millimeters of mercury, which is a normal according to the guideline. So, and when the systolic pressure is less than 60 in any person, definitely there will be some other underlying cause. And I won't generalize as a treatment. That patient needs to be elaborately assessed. Real cause has to be identified, and diastolic pressure of diastolic pressure of less than 60 also is a cause of concern. A systolic pressure of less than 60, patient would not be in a viable condition. It questions a viability. But a diastolic pressure of less than 60 also needs a very elaborate assessment, and rarely you get such patients, and they may be having either a severe hypoaldosteronism, aldosterone pathologies could be there, or a severe hypothyroidism, very severe critical hypothyroidism patients, and they need a totally different approach to the treatment. A general approach to the treatment like a low BP and a calcium injection being given, or multivitamins being given, or vitamin E being given, which is a usual prescription which is done in the usual practice, definitely is not a standard disease entity, a pharmacological entity. That's it.
Questions?
Regarding Lasun, earlier we are prescribing in dyslipidemia.
Yeah, that's
you
true.
told that Lasuna is not indicated.
Statistics, you have the whole problem is The Western publications, they would be depending upon the alkaloids. A Lashun alkaloid would show a high antihypertensive, it is a hypertensive effect, as with liquoric acid, which is also known to be antihypertensive, but hypertensive as such. And once this has been established, particularly USA, FDA, that they are very rigid about that. And in the USA, there is a general guideline given to the physicians, like if a patient is taking any herbal drug, and particularly people of Indian origin going to a Western doctor for the prescription, they would be advising the patient to avoid garlic in the food. It has come to that stage. Madhuyasti, that one of that liquor, earlier that licorice extract was being used for that mouth ulcers. Now that's banned. That's banned in the Western countries. That's the existing situation. From our point of view, definitely yes. In a kafaja avarana lakshanas, it's lashun, garlic is definitely one of the remedy which you can prescribe.
Practice. Recently, I have got 2 patients below the age of 30 years, around 26 years. With the systolic pressure more than 150, around 170 or 180, and diastolic more than 96, without any symptoms, sir. Whether they need treatment, accidentally they are found to be hypertensive, whether they need any treatment or...
Okay, I recommend a thorough investigation in that patient. There could be an abnormality of the adrenal glands. Adrenal functions have to be particularly these metabolic products, CAMP products have to be assessed in the urine, and that needs to be. Younger patients, less than 20 or 30s in that age, having a very high blood pressure, most of the times there will be hyperaldosteronism, abnormality related to the adrenal gland or the addiction forming or other medicines. These are the 2 most common conditions from as far as my experience is concerned. So VMA, urinary VMA, vinyl mandelic acid assessment is mandatory. A patient coming to me with that kind of history, I would be having a VMA assessment, and if there is a hyperaldosteronism, then the whole cause has to be assessed thoroughly. At times, he may require a surgical treatment also, patient may require adrenalectomy also. That depends upon more detailed approach. I don't consider that could be something where we can manage with only simple drugs and so on. That patient requires elaborate assessment. Right.
Thank you, sir.
And I have the credit of identifying that suprarenal tumor, and then of course the patient now is healthy after surgery. So this was around 5-6 years back, somewhere in 2012 or 13, a 12 years old patient, and usually practitioners don't record the blood pressure of below 20, but I record the blood pressure of almost every patient. I almost, except in children I may not. Otherwise, any patient, whatever the complaint, one of the usual things is I do push regularly. And that helps in the other way also. It gives you some opportunity to have a communication with the patient also. A rapport is developed. But I think I claim that credit of identifying that patient in that age. So I remember that as one of the acclaimed case in my practice. So, right.
After the first session, I have purchased more than 100 tins of Prutyanjarasa with good result in Jwara and upper respiratory tract infection. Thank you, sir.
It is feedback. I have some questions to sir about last time's this one. So how patient presents was with diabetes mellitus. He said the treatment of Hasanadi Gana Kashaya, Arogyavardhini and Chandraprabha in most of the cases a type 2 diabetes mellitus. What we see in our clinical practice, I think all of you clinicians, you have this experience. See, some patients with the diabetes of 300 or 250 milligram blood sugar, they come with a very heavy built fellows. Some persons are moderately built. They have Svedadikyata or Kshudadikyata and tense mind, these things, these variations. Some persons have, and these 2 categories what we have seen is Their muscles are, a heavy built will have a ghana muscle. A moderate built have shitila, a mrudu muscle. If you feel it, you can feel it. And some other category, they may be heavy, at the same time Svedadikyata and Kshudadikyata, Trishna, all these things, Brahma, these symptoms will be there. Are you going to give same treatment for everybody? Is there any change? How you will change it? Why I am asking is this question. If when we go through our textbook, Samhitas, especially in Ashtanga Sangraha, then Madhavaidana he elaborated it. What he says, he tells Prameha is 20, 10 is Kafaja, 6 Pittaja, 4 Vataja. For that in Vataja Prameha, he tells about Madhumeha. Madhumeham Madhu Samam Mehati Sa Kila Dvida, these two types. Kruddhe Dhatukshayat Doshavrata Patho Athava. One type is due to Dhatukshaya. Another type is Dosha Avaranat Vata Prakopa, you are getting Madhumeha. When he tells this one, then Vijaya Rakshita, he is a Tikakar, he elaborates it. What this Dosha Avrata means? Dosha Avrata will be both Pitta and Kapha Avrata Vataja Madhumeha. Here, he explains that means Madhumeha becomes 4 types. One is Dhatukshaya. Dosha Avarana will be 3 types. One is Kevala Kapha Avrata, second one Kevala Pitta Avrata, third one is both Kapha Pitta Avrata. Are you going to treat the same drug for all these categories? Then here again he says, a Kapha Avrata will be, there will be Ghana Mamsa and patient will be sleepy, these symptoms. A Pitta Avrata will be, he will be Daha, Brahma, Kshuddha, these symptoms will be there. Whereas a Kapha Pitta Avrata will have both mixed symptoms. How you will treat such cases? This is one question. Second question as I will ask now itself. So now we have categories, 2 types of population. One is with Madhumeha, another one is without Madhumeha. A Madhumeha patient comes to us with different diseases like Jwara, Atisara, all these things. When you treat such cases, this is happier okay, how your patient is taking Asanadikana Kashaya, all these drugs. When they come with these diseases, how you modify this treatment? Because a Jwara patient, you should not give Kashaya Rasa Dravyas. But here we are giving Kashaya Rasa Dravyas. So when Amapachana we have to give Tikta Rasa Arishta or for Agnimandiya Amapachana Dravyas. How you will manage these diseases? And he said about complications of especially chronic renal failure. I think I am also using same treatment for last many years. Excellent treatment, we get very good result. So with this feedback, I want some answers from sir. Thank you very much.
I hope I have already referred to that issue in the last presentation. I have quoted about that statement also, but maybe I have not elaborated to that extent. The basic issue is about Ashtanga Sangraha, describing about that Dhatukshayajanya Vata Prakopa and the Mamsa Shratagata produced in case of the Avarana, Avrata Vata. The same is described by Charaka as a Krisha Pramehi and Sthula Pramehi. That's only the issue is Vagbhata has given more detail. I think I have referred to that issue in the last presentation. In the slide, there is that shloka is still there in the slide probably. But I have not elaborated, maybe I have not discussed that issue in detail. As far as the treatment prescription is concerned, from my point of view, I consider Krisha Pramehi always as a difficult condition, and I think I have referred to that issue. Many of the insulin dependent patients are of that category. So if there is a insulin dependency sign, I have very clearly mentioned, like I may not manage only with our drugs, insulin may be required, and then along with our drugs, insulin requirement may be reduced or modified in due course of time. Then as far as the Avarana and the variations are concerned, I think I have suggested about the possible prescriptions variations also in the same category. Asanadi is a common drug which is described, but in some of the patients it's the Chandraprabha and Arogyavardhini. In some of the patients I have suggested about the Gokshuradi Gugulu and the Chandraprabha, and in some of the patients the Diabicon, the brand name, which contains this Vangabhasma content. Now it's about the Vangabhasma, which is the most important issue than that brand as such. My idea is in that condition where you have a Pittavarta Lakshanas, majority of the patients with the Sveda and so on, they have that Pittavarta Lakshana. Chandraprabha, Arogyavardhini and Asanadi helps a lot in that Avartavata conditions, which I consider usually as a Stula Pramehi. That's the part. So, Krusha Pramehi is the other part where the insulin dependent issue needs to be considered as such. Then the real Kaphavrata conditions, Sthaulya, where the patient has a real obesity, in that condition you may require the treatment like Gokshuradi Gugulu. That's what also I think I have referred to that part also in the prescription along with the Asanadi. Many a times I manage the patients with simple Agnitundi also. Some of those patients who are transient, seeming to be hyperglycemia, may not be having the diabetes. Simple Agnitundi also prescribe for a short duration, see the follow-up, repeat the sugar level, after some advice about the diet. A good number of patients, they may have a normal blood sugar level in that condition. So, Sthula Pramehi, comparatively easier to treat, but difficult to maintain the diet restrictions. Sthula patients, they tend to have that urge for food more, which is insuppressible as such. So, that's what I feel. So I think that's how I assess that part. But that issue of Avarana producing the Prameha is a very good suggestion, and from the practical point of view also, it has some significance. We can identify such patients easily. And my safe line is Krusha Prameha is considered as the other way. That's about the first question. The next question is about the sugar. Huh? I think I have clearly mentioned, like, if the patient has a stabilized treatment for the hypertension, and when he comes for other conditions, I don't interfere in that. That part is considered as such. I prescribe, I think I have quoted very clearly, I have stated, I have no inhibition in prescribing any of our drugs, including Sharkara Yukta Churnas or the Asavaristas. Asavaristas, absolutely, I never have any hesitation in prescribing that. Sharkara Yukta Churna like Sitapuladi, Avipattigara, etc. Also I do prescribe without any hesitation. It doesn't affect as such. The issue is the total quantity of so-called sugar content in that drug is not enough to produce a fluctuation in the patient's blood sugar level conditions. I think that part also we have discussed about that diabetogenicity, calorie content part also we have discussed. That calorie content part of our medicines is virtually negligible. Maybe I may have a reservation when I prescribe some lehas, Ghrutayukta lehas like Chavanaprasha, Ashwagandha leha. These I may not generally prefer to prescribe in a patient of diabetes patients, considering because it has a high calorie value. Not that it is contraindicated. So, and probably I might not have any opportunity to prescribe those also in such patients. Maybe that's what I feel. But as far as the other medicines are concerned, virtually no need to worry about that. Right. Meha is an existing precondition, and Jara is an overlapping condition. So that existing precondition, we will not touch that. Only that the Vyadhi of recent origin, in a Vyadhi Sankara, you will have to have that background. One of the Vyadhi has considered as a background. The disease for which the patient is presented, we will be managing that. And I have no inhibition. We will not discontinue those anti-diabetic drugs also.
What we have one question is, how you are what is the basis of selection of drug for all these diseases? What is the reasoning of the drugs? Or from next time itself, if you...
It's about only the doshas.
If you explain this thing when you give lecture, it is better, I think so.
I think wherever possible, I have referred to that issue. Maybe, okay, fine. So in the next presentation, I will do that, like among my prescriptions of 32 drugs which I select,